Hello friends, I'm Dr. Rajesh Chokhani, a general pediatrician from Bandra, Mumbai, and today we will be talking about interpretation of gait abnormalities. So friends, observation of gait gives us a lot of information about the affection of tone, power, coordination, etc. So before going on to abnormal gaits, let us understand the components of a normal gait. When the foot makes initial contact with the ground, then progresses sequentially through the subsequent phases of gait, and then when the same foot comes in contact with the ground again, this is known as one gait cycle or one stride. This is divided into the stance phase and the swing phase. The stance phase is when the foot is on the ground. It is further divided into the initial strike when the foot first strikes the ground, which as we all know is commonly the heel which strikes the ground, and then the subsequent push off when the foot immediately after which the foot just leaves the ground to get into the swing phase. The swing phase is the phase when the foot is off the ground. So it is the phase which is transitioning between two stance phases. Again, it is divided into the initial accelerating phase and then the subsequent decelerating phase just before it hits the ground again. Besides, incidentally, there is something known as a float phase, which is actually seen only in running gait when neither foot is on the ground. Now, to assess the gait correctly, we must make the patient walk to and fro for a few meters with the lower limbs exposed and preferably the feet bare on the ground. Besides carefully observing for each of the components which we just discussed, we must also look at the position of the head, the trunk, the position of the hip, knee and ankle and the motion, the arm swing and the stride length and asymmetry. To unmask a hidden abnormality, it may be worth making the child run, because this brings out an abnormality which is otherwise either compensated by the child or due to his self-consciousness we are not able to make it out. Similarly, if we make the patient hop on one leg and then on the other, or if we make them walk on their toes and then on their heels, if they are developmentally able to do so, then these maneuvers also bring out minor subtle weakness or abnormalities. Now let us look at some abnormalities in gait that we can see and how we interpret them. When there is a pain in the lower limb on weight bearing, the patient is likely to lift the foot quickly off the ground, so the stance phase is shortened. This is known as an antalgic gait. When the knee does not extend fully in the stance phase, it means either there is a knee abnormality or there could be a possibly limb length discrepancy. When a patient presents with a limp, it is likely to be a unilateral problem, and in case it is a bilateral problem, the affection is unequal, resulting in a limp. Spasticity can give rise to various types of abnormalities in the gait, depending on whether spasticity is unilateral or bilateral and whether the degree of weakness is mild or severe. When bilateral spasticity affects the lower limbs, the gait is narrow, scissoring gait, where both the thighs and the knees are brought close to each other because of the increased adductor tone, sometimes to the point of scissoring. These patients may also have toe walking because spasticity leads to persistent plantar flexion. When spasticity is unilateral and as seen in hemiparesis and the hip flexors are not so weak, then we may see a circumduction gait where the lower leg is moving out in a circle in the swing phase. The reason is that spasticity and the consequent plantar flexion makes the lower limb longer, and the patient finds it difficult to clear the ground in the normal style of walking. So by this circular movement they are able to clear the ground better. In this hemiplegic gait, the arm swing is also limited and the arm may be partially flexed at the elbow. When the toes strike the ground first, it may be due to a spasticity as we just talked about, but it can also be due to a spasm or tightening of the tendoachilles, which results from an imbalance of the strength of the foot flexors and foot extensors, as is seen in Duchenne muscular dystrophy. Toe strike is also seen in foot drop, which is a peripheral neuropathy, and here we classically see a high stepping gait where the lower limb is brought higher at the level of the knee by flexing the knee so that the foot drop can clear the ground, and then the foot is brought heavily on the ground. As opposed to this, there is another high steppage gait of sensory ataxia where the heel first strikes heavily on the ground because the proprioception sense is affected, and then this is followed by the whole sole slapping flat on the ground. This kind of a high steppage gait, sensory ataxia gait, is also wide based and the stride length is small. Patients with dystonia tend to walk on the outer edge of their soles. Any child or patient who has a difficulty in maintaining balance will have a wide based gait with a small stride length known as an ataxic gait. This is typically seen in cerebellar or even vestibular disorders. Let's understand a waddling gait. Normally, when the lower limb is off the ground in the swing phase, the ipsilateral hip tends to dip downwards due to gravity, but is prevented from doing so by the contralateral gluteal muscles which stabilize the hip. Now, when this dip is actually seen, it is known as a Trendelenburg gait, and when this is seen bilaterally, it gives the classic appearance of a waddling gait as is seen in Duchenne muscular dystrophy or bilateral developmental dysplasia of the hip. Children with Duchenne's also have exaggerated lumbar lordosis. Talking of lordosis, a child with a massive abdominal distension will also have a lordotic gait in order to try and maintain balance while walking. When the Trendelenburg phenomenon or the downward displacement of the hip is unilateral, it suggests a contralateral hip pathology like a unilateral developmental dysplasia of the hip or a slipped capital femoral epiphysis or a avascular necrosis of the hip, where the contralateral gluteal muscle is either weak or in spasm and is therefore unable to stabilize this hip. Let us understand the Parkinsonism gait. In Parkinsonism, the steps are short and the feet barely clear the ground, giving the appearance of short shuffling steps. To compensate, the patient tries to walk faster, and this, coupled with the upper body being moved slightly forward, it gives the classical appearance of what is clinically described as chasing one's own shadow. Also, there is a phenomenon of freezing of gait where there is a initiation hesitancy and a turning hesitancy. So, these patients find it difficult to initiate walking, and at the point of turning, they accomplish a turn in multiple series of small steps without turning their neck and trunk, that is the face or the head and the trunk is held rigid. So this is known as en bloc turning, and this is classical of Parkinsonism. So friends, we saw that there are different types of gait abnormalities depending on the neurological abnormality, and analysis of the gait gives us a lot of information. In fact, nowadays laboratory techniques are used to analyze gait after it has been captured on camera. So at least as clinicians, we must make an effort to clinically observe the gait and get as much information as possible. Thank you. The next video will be by Amdekar sir on a recap of the last few videos.